Good afternoon. My name is Dr. Leslie Kerr. I'm a clinical rheumatologist, but I have had a great interest in my own area of subspecialty as a geriatric rheumatologist and have practiced alongside the Mount Sinai geriatricians for many, many years now. And it is my pleasure to describe crystal arthropathies, which are acute inflammatory arthritis related diseases caused by different crystals. And these entities are very prevalent in the geriatric practice. So I hope to give you a greater understanding of the diagnosis and management of these problems. Here's a summary of some of the crystals that we find that cause synovitis and synovial fluid. The most common, of course, is monosodium urate. We recognize acute gout as the major synovitis. We also, over many decades, see a small minority of the gout population develop TOFI, known as tophaceous gout. But largely, patients with hyperuricemia may remain asymptomatic. The second most common kind of crystal synovitis that I see in the geriatric practice is due to calcium pyrophosphate dihydrate, CPPD disease, as it's also referred to, and it can cause acute pseudogout. It can also, when smoldering and polyarticular, mimic rheumatoid arthritis and is known as pseudo-rheumatoid pseudogout with a somewhat destructive characteristic. And chondrocalcinosis, which is the calcium pyrophosphate crystals seen on X-ray, can also be asymptomatic. There's basic calcium phosphate known as calcium hydroxyapatite. When it clusters into a clump, it can cause an acute calcific bursitis of the shoulder. It can rarely cause a polyarthritis, usually in dialysis patients. And when finally dispersed through shoulder synovium, it can cause a destructive arthropathy localized to the shoulder known as Milwaukee shoulder. Calcium oxalate we rarely encounter, very rarely in dialysis patients only. And lipid cholesterol, we see these pretty cholesterol crystals in synovial fluid, but they rarely cause synovitis. So I'm going to start with gout, which is the most common crystal-induced synovitis that we see. And unlike rheumatoid arthritis, which is a modern disease, gout has a long history and is an ancient disease with descriptions of it going back as far as the 5th century BC. And many of its characteristics were aptly described in those distant centuries. It appeared to run in families. We've known this since the 1st century. Tophi were described in the 3rd century. Crystals were seen in the tophi in 1679 with the advent of microscopy, as well as in tophi 100 years later. We had therapies that have withstood this test of time, colchicine since the 1800s. The recognition that urate crystals cause an inflammatory arthritis, cause gout. And then many effective therapeutic agents introduced since the 1950s with allopurinol, developed originally at Mount Sinai, very much withstanding the test of time as it is our major uric acid lowering modality to this day. There are 4 phases of gout. There's a long phase of asymptomatic hyperuricemia, which we do not treat, although there is some discussion about whether or not that should be treated. Currently, we do not treat asymptomatic hyperuricemia. Then there is acute synovitis, known as acute gout. Once that resolves, the patient enters what we call the intercritical period, which is the period of time in between attacks. And this interval may be 1 week, or it may be the rest of the patient's life. So you have to look at the risk factors to predict recurrence. And then a chronic phase after many years of hyperuricemia and acute gout, known as chronic tophaceous gout. And I'll be describing all of these. What are the features that lead to hyperuricemia? Well, in most patients, it's underexcretion, dehydration, abnormal renal function is probably the major contributor, as well as medications that patients are commonly prescribed, such as low-dose aspirin and diuretics. And then, of course, the common toxin, alcohol, which is the double whammy because it leads to underexcretion, but it also stimulates purine synthesis, which leads to overproduction of purines and uric acid. There are some relatively rare deficiencies of enzymes in the purine metabolic pathway, partial deficiencies of HGPRT, and superactive PRPP synthetase. These are rare deficiencies that will lead to synovitis in families, and you see male probands particularly affected with these problems. Psoriasis, which causes overproduction of skin cells, is a form of overproduction of purines and can lead to superimposed gout in addition to psoriatic arthritis. And myeloproliferative diseases due to ineffective erythropoiesis are commonly causes of urate overproduction and acute gout. So acute gout can be either monoarticular or polyarticular. In fact, 80% of acute attacks are monoarticular, which leaves 20% of initial attacks being more than one joint. How does it present? Well, there's usually the abrupt onset of severe joint inflammation, often at night. 75% of first attacks are in the first MTP, that's the big toe joint. If you do nothing, it subsides completely in 3 to 7 days, which should temper your enthusiasm for poisoning your patient too much, because even if you do nothing, and I'm not advocating doing nothing, but even if you do nothing, it goes away on its own without any permanent joint damage. So we need to demand a very high level of safety for the medications that we do use to get patients out of their acute arthritis flare. Uric acid crystals are seen in synovial fluid, so we get very excited because we can actually make a specific diagnosis. And uric acid levels are not particularly useful when measured during an acute attack because they can be high, they can be normal, or in the case of a polyarticular attack, the serum uric acid may be low because all the uric acid has been crystallized and shed into joints. So I would recommend making your measurement in between attacks once an attack is resolved to get an adequate or more accurate reading for where they are in the hyperuricemia spectrum. There's a wonderful description from Sidingham from the 1600s that is still accurate today. And I'll just read a little piece of it to give you a flavor of what it's like to have a gout attack. The victim goes to bed and sleeps in good health. About 2 o'clock in the morning, he is awakened by a severe pain in the great toe, more rarely in the heel, ankle, or instep. The pain is like that of a dislocation. The parts feel as if cold water were poured. Then follows chills, shivers, and fevers. The pain, which was at first moderate, becomes intense. Then it comes to its full height. It then becomes a violent stretching and tearing of ligaments, a gnawing pain, and a pressure and tightening. So exquisite and lively is the feeling of the pain of the part affected that it cannot bear the weight of the bedclothes, nor the jar of the person walking. And it goes on and on and on. But you get the sense of how it attacks you acutely at night and becomes a severe pain so that even the bed sheets cause pain. And here's how it looked to lithographers in the 1700s as if the devil was gnawing on your swollen and inflamed toe. And here's how it looks in the flesh. And this is actually a polyarticular, oligoarticular attack. You've got 3 joint areas, an inflamed ankle, inflamed tenosynovitis over the dorsum of the foot, and of course that markedly inflamed first MTP known as podagra. So this patient can't walk. This is disabling. And again, here's another artistic rendering. You've got your glass of port here, which is the great etiologic agent that blocks both your uric acid excretion and leads to overproduction. So you get the hot foot and the hot ankle, and it's as if the devil is heating it up. What are the risk factors? Well, there's some rare genetic risk factors that I've already mentioned. Increased weight or losing weight delivers more purines and for metabolism and is a risk factor for developing gout. Advanced age is a risk factor, which is why I see it in the geriatric practice, and I believe that it's linked to a decrease in GFR, even if the serum creatinine is normal, which comes on with advanced age. And then think of all the patients who, for all the correct indications, are on low-dose aspirin. and or diuretics. As a transplant center, we used to use a lot of cyclosporin. These patients had intractable gout, but we couldn't stop the cyclosporin because we would lose the graft. Now with mycophenolate and tacrolimus, gout is less of a problem in transplant. I've already mentioned alcohol. We have marked degrees of patients with renal impairment and acute illness. So this is why I see acute gout so often when I'm on the inpatient consult service. That combination of starvation, ketosis, and dehydration that we get in acute illness also leads to attacks of gout in patients that have never had gout before. What is the synovial fluid like? So if it's one joint other than the big toe, the joint needs to be aspirated in order to rule out septic arthritis, because this is a very hot, angry-looking synovitis that mimics septic arthritis, and the fluid will be inflammatory with a high white cell count. It will be a polypredominance, but reassuringly, the glucose will be normal, as opposed to a septic arthritis where the glucose is low. The gram stain will be negative, and if you look under a polarizing microscope, you will see negatively birefringent uric acid crystals that are located intracellularly, and that enables one to make the diagnosis of acute gout and to rule out septic arthritis. And here's how it looks. So under a polarized microscopy, you see this poly, and it looks like it's been harpooned by this thin needle-shaped crystal, and the polarizer is oriented parallel to the long axis of the crystal, and that's the definition of negatively birefringent crystals. They lose light, look yellow or white when the axis of the crystal is aligned with the axis of the polarizer. But you don't need a fancy microscope to make a crystal synovitis diagnosis. Here it is just under 40x, regular microscopy. You take a slide, you put a drop of the fluid on the slide and a cover slip, and you look. And if you see morphologically this long needle-shaped crystal harpooning the cell, you know that you have acute gout. So how do we treat gout? And I'm not going to repeat this because the treatment is pretty much the same as for pseudo-gout, which I will be describing next. High-dose non-steroidal anti-inflammatory drugs with indomethacin 50 milligrams 3 times a day being superior to all other medications. But I must tell you that having said that, there is no one in the geriatric practice who I would treat with a high-dose non-steroidal anti-inflammatory drug. Why? Because after the age of 65, you're much more dependent on renal prostaglandins to maintain your GFR. So older patients are much more likely to have AKI given high-dose NSAIDs. They're also much more likely to bleed. They also may have hepatic dysfunction as a baseline, and therefore you don't want to use high-dose NSAIDs. Half of the patients I see are on anticoagulants, and it can cause mental status changes. So although by the book, high-dose NSAIDs are the treatment, I would only be using these in much healthier, younger patients with gout without the comorbidities that I mentioned. I never use this amongst my geriatric patients. Colchicine for acute treatment is given in 2 ways: 2 pills initially, followed by 1 pill 12 hours later, or oral colchicine loading, 1 pill at the first presentation, then an hour later, another pill, with no more than 1 pill an hour and no more than 6 pills until either relief is achieved or mild GI toxicity. That's kind of an unpleasant treatment, and if renal function isn't completely normal, it can be more hazardous because you will run into GI toxicity. Remember that colchicine works by inhibiting microtubule assembly, which means that it works by preventing the white cells from getting into the synovium where the crystals are shed. And this is a transient feature. So if the attack by your history has been going on for 48 hours, colchicine will not work. All the white cells are in there already. It won't block the white cells from coming in. So I wouldn't even consider it if the attack's been going on, say, for 3 days. Intra-articular steroids is an effective, safe topical therapy, but it only works if you have 1 or 2 joints. You can't inject multiple joints, and you have to be absolutely convinced that you have ruled out septic joint in the joint that you're going to inject. ACTH was a very effective therapy, worked faster and was more effective than steroids, but has been taken off the market. It's back again as Acthar gel for use in myositis, and it's thousands of dollars. So we're not using it for acute gout. So pretty much what we're left with is steroids in our older patients, and the dose is proportionate to the number of joints involved. So if it's 3 joints, it's going to be about 30 milligrams of prednisone with a taper. 6 joints, 60 milligrams of prednisone with a taper, but it does work. And even if you think that a patient meets criteria for uric acid lowering, this step is never pursued during the acute attack, because in that inflammatory milieu of an acute gouty attack, if you were to introduce uric acid lowering agents, you will induce such rapid fluctuations of uric acid across membranes that you will convert a mon or oligo-articular attack into a rip-roaring polyarticular attack. So if you think the patient meets criteria for uric acid lowering, you make a mental note of it. You put the patient on colchicine prophylactically to lessen the possibility of a severe attack when you introduce your uric acid lowering agent, and you bring the patient back to your office 1 to 2 months later after every element of the inflammation is resolved, and then you gently introduce the uric acid lowering agent at low dose. Never in the acute attack, always after the attack is resolved, if it is indicated. So again, past advantages for ACTH, it just worked faster. It didn't cause adrenal suppression. And there were many fewer steroid side effects, and we wrote about it, but unfortunately it's no longer available. Once you get your patient out of the acute attack, they enter an asymptomatic period that we call the intercritical period. At that point, it's important to look at the diet as well as medication modification. If they're just on the diuretic for control of mild high blood pressure, perhaps you can stop that and treat them with something else. You might consider colchicine prophylaxis if you think that their intercritical period is going to be short, and that would apply to, say, someone who's had 3 attacks in the last 3 months. You can guess that it's going to come back. Or someone who's going to need continued aggressive diuresis for heart failure or for control of volume for renal insufficiency. And this is determined, the dose of colchicine is determined by the serum creatinine. So if it's normal, it might be 1 or 2 pills daily. If the creatinine is 1.8, it might be 1 pill daily. If it's over 2, it may be half a pill daily. If it's higher than that, it may be half a pill 3 times a week. And if it's a patient on dialysis, it will be 1 pill once a week, no more than that, because colchicine is not dialyzable. And then if it's something where they never had an attack before, and there was a precipitating reason like an acute medical illness or a big barbecue event, for example, no treatment may be necessary. This may be sufficient, and they'll never have another attack of gout. So you have to look at the patient and individualize it. Chronic tophaceous gout is something we see in only a minority of gout patients. Common locations are the ear, illustrated here, these yellowish deposits, the distal digits, here's a tophus, or the olecranon bursa. It can be quite deforming if it continues, and illustrated here you can see huge tophi. This one is draining this yellow material, and if you rub this material on a slide, you would see uric acid crystals in all directions. You can see tophi and the olecranon bursa. So it can be quite deforming and disruptive of hand function if it's not treated. And fortunately, this is a very rare event these days. Much earlier on, before we see such huge tophi clinically, we can pick them up on x-rays, and I always x-ray the feet of any patient that I'm meeting for the first time with gout to determine whether or not radiographic tophi are visible, even though I may not see them on clinical exam. And here's a typical tophus illustrated here. You have preservation of the joint space, but you have loosened erosion with an overhanging edge and a soft tissue mass. So that's the classic early tophus. Here's some with much more advanced tophaceous gout. The joint space is now narrowed. The overhanging edge is still here. There are multiple erosions with a huge soft tissue mass, another soft tissue mass with erosions, overhanging edges in multiple places, dissolution of the bone where it has been replaced by a huge tophus. And if you were to stick a biopsy needle in here, you would see uric acid crystals, a pure sequestered precipitate with no white cells. And here it is. It's the most beautiful crystallography. If you just make the background black, you see crystals in all directions. If you put on the polarizer, those that are parallel will lose color and be yellow or white. Those that are perpendicular have the blue-purple color, the definition again of negative birefringence. So what are the indications for uric acid lowering therapy? Well, someone who's having recurrent attacks despite colchicine prophylaxis, they're truly disabled by these multiple painful attacks of synovitis, so you want to target them. Anyone who has a history of uric acid renal stone. So if you don't ask the question, have you ever had a renal stone, you are missing an important indication for uric acid lowering. And anyone who either radiographically or clinically has the presence of a tophus. And the reason for that is we want to prevent the destructive arthropathy, but more important, within the patient population who are tophi formers, some of them are going to be putting microtophi into the kidney, causing chronic urate nephropathy. And we very much want to prevent renal destruction from tophaceous gout. So these are the indications for treatment. Notice it's not the level of uric acid measured. It's these three clinical features. And then an indication that is not germane to my practice, we see high-dose uric acid lowering therapy given to oncology patients prior to the initiation of chemotherapy to prevent tumor lysis syndrome. So how do we think about our therapeutic armamentarium? Well, we have patients who are under-excretors, and we have patients who are over-producers. And by the book, if you were an under-excretor, then your most specific treatment would be a uricosuric agent, which acts locally, stimulating the kidney to excrete more uric acid. If, however, you were an overproducer, you're already having excellent excretion. So the theory would be that the most effective treatment would be to block the synthesis of uric acid by using a xanthine oxidase inhibitor. So by the book doesn't often work out that well because many of the patients who are under-excretors are obligate under-excretors because they have renal insufficiency. So if the creatinine is greater than 1.6, by definition, they'll have a low uric acid in their 24-hour urine, but giving them a uricosuric won't work because they work at the level of the renal tubule in the setting of no impairment of tubular function. So although patients with renal insufficiency are under-excretors, uricosurics are not going to help them. Similarly, if a patient must remain on diuretic because of CKD or congestive heart failure, the diuretics are going to block the ability of the uricosurics to work. So there are many patients who are under-excretors who we know will be from their renal insufficiency or their diuretic use that will have to go straight to medications that block uric acid production. Sulfenpyrazone is used commonly in Europe, but has never been used here. And benzbromarone actually works up to a creatinine of 2, but was not given FDA approval due to hepatic toxicity. So it's not available, but just for completeness. Lenissurad was also interesting, was used in combination with xanthine inhibitors, but was also removed by the FDA for toxicity. So what we have available to us is probenecid, which we can use in that small segment of the population who are under-excretors, but do not have renal insufficiency or diuretic use. Mostly, therefore, we are turning to xanthine oxidase inhibitors, with the most commonly prescribed being allopurinol, the oldie but the goodie. And here's where measuring the uric acid is very important, because once you decide that someone's uric acid should be lowered, then you really want to get that level down to under the solubility of uric acid in serum, which is a level of less than 6.2 milligrams per deciliter of uric acid. So you want to see where you're starting so that you know what your target is and get a sense of how long and how high the dose will be to get to that goal, at which point gout should more or less drop out of that patient's life. So again, allopurinol is not one size fits all. The way I use it is I start very low. I've already blocked them with prophylactic colchicine for a few weeks and they have no evidence of an acute attack. And I introduce it at 50 milligrams, so that's half of a 100 milligram tablet for a few weeks, followed by 100 milligrams for about a month or so, And then I bring them back and measure the uric acid. If it's still above 6.2, I'll go to 200 for a couple of months, and then 300, which is a different pill, a 300 milligram pill. But that's not where I stop. Okay, again, you want to get to 6.2. So if you're on allopurinol 300 and they're taking it daily and the uric acid is still 9, you're going to go higher, and you can safely go up to 800 milligrams of allopurinol a day if there are no side effects, in order to get your uric acid to that target of less than 6.2 in that patient. There's also another xanthine oxidase inhibitor that was FDA approved in 2010. It's known as febuxostat, also known as Uloric. In a head-to-head comparison with allopurinol, it was touted to be a more potent uric acid lowering agent. I don't think that that's true, because they only compared 300 of allopurinol to full dose febuxostat. If you, as we do in common practice, elevate the allopurinol level higher than 300, I think it's comparable. But I think that febuxostat is a useful niche drug, because we do have a small but significant segment of our gout population who are intolerant or allergic to allopurinol. And there's no crossover between having a toxic reaction to allopurinol and having one to febuxostat. So it's a very useful adjunct to our armamentarium for those patients who cannot take allopurinol. And then a new universe when pegylated uricase, known as pegloticase, was developed for use in acute gout. And again, the ability to make this therapeutic product stems from an understanding of the etiology of the synovitis. We know that it's hyperuricemia, which leads to the creation of uric acid crystals. And so we can target the production of uric acid by developing this long-acting uricase. And so the story is very interesting. When you look at the animal kingdom, uricase is conserved amongst mammals, except in humans and in, I believe it's orangutans, who lost uricase as a mutation during evolution. And it may be that losing uricase was protective against dying from overwhelming infection, but that is just a theory. It has not been proven. So we and this one ape-like creature are the only ones who are susceptible to developing problems with gout, because we as species have a uric acid that hangs out very close to the solubility of uric acid in serum, around 5 to 6, whereas the rest of the animal kingdom that has uricase walks around at 2 to 3 milligrams per deciliter. And so understanding that we lost uricase in evolution and that uric acid is the culprit, it made sense to infuse pegylated uricase. And it's an amazing drug. For those who are intolerant of allopurinol and febuxostat, you see the uric acid drop from 12 at the beginning of the infusion to 0 at the end of the infusion. It's amazing. And if they have tophi, the tophi start to visibly decrease in size within a few days. So it's truly an amazing thing. However, allergic reactions develop particularly over time. Because it's a porcine protein from which it's derived. And so you have to first make sure they're not G6PD deficient so that they can metabolize it. And second, you have to measure the serum urate before every infusion. And when the serum urate is above 2, you know that you're developing that blocking IgG, and the next infusion, you're going to have a severe allergic reaction. You have to stop. So many practitioners who use pegloticase will start either low-dose methotrexate or azathioprine, depending upon the patient's comorbidities, to prevent the development of the blocking IgG so that pegloticase can be given in the long term. And then for refractory inflammation, and these are very rarely needed, we experimentally use interleukin-1 receptors such as rilonacept, anakinra, or canukinumab. Canukinumab was specifically developed for the treatment of acute gout, but was not approved by the FDA because of its marked risk of infection in patients who have severe gout, obviously who have a lot of comorbidities that make them more susceptible to acute infection. So these are experimental. They do work when nothing else works for the acute attack, but they are not FDA approved. So having summarized the clinical features and the therapeutic modalities for the treatment of gout, I now want to spend a few minutes talking about the second most common crystal-induced synovitis, namely pseudogout or CPPD. Like gout, its initial presentation is usually monarticular, although a small percentage may present with polyarticular disease. The pattern, however, is different from gout, and that serves as a clinical clue. Unlike gout, where the most common joint affected initially is the first MTP, followed by the instep, followed by the ankle, followed by the knee, in pseudogout, the pattern is different. The most commonly affected joint is the knee, followed by the ankle, followed by the wrist, followed by the shoulder. So initial monarticular attack affecting an upper extremity joint is very common in pseudogout and would be extremely uncommon as an initial presentation of gout, with wrist and shoulder involvement only being seen in a gout patient who has all the other lower extremity joints already inflamed at the same time. So just by the pattern, you can make a guess that you may be dealing with pseudogout rather than gout. Again, it's an inflammatory synovitis, so we see a high white cell count, but usually not as high as in gout. It has a polypredominance. Glucose, again, is normal, which is reassuring against it being a septic joint, and the gram stain being negative also serves to reassure. When you look at it under polarized light, however, you will see small, intracellular, stubby-shaped, positively birefringent crystals, which is the physicochemical property of calcium pyrophosphate, as opposed to the negative birefringence of monosodium urate. And here's how they look. These are much harder to see. When you're looking under plain microscopy 40X, these are short, stubby crystals. They don't stick out of the cell. Sometimes I feel like I can't see anything. I make the polarizer feel completely black, and then I can pick out these small, bright crystals which morphologically look like CPPD because they're not long and needle-shaped. And when you put on the polarizer, again, when its long axis is parallel to the axis of the polarizer, it has the blue-purple color, which is the definition of positive birefringence. When you change the polarizer to perpendicular, it loses the color, again, cementing the diagnosis of a positively birefringent crystal CPPD pseudogout. Now, sometimes x-rays can be very helpful, especially if a patient comes in complaining that they had an acute synovitis of the knee or of the wrist or of the shoulder, and by the time they see you, it's resolved. So you get the sense that it was a crystal, but you don't know which one because there's nothing to see or tap on exam. If you happen to have an old knee film hanging around, and you can observe this stippled calcification in the joint margin, known as chondrocalcinosis, that is a huge clue that you were likely dealing with acute pseudogout that resolved. And the same for the wrist. Here's the chondrocalcinosis in the triangular ligament of the wrist. Okay, and you can also see it hugging the humeral head in the shoulder. And again, these are the most common places which can be affected by pseudogout. Seeing chondrocalcinosis on a film in any of these sites markedly increases your index of suspicion that the synovitis you're dealing with is acute pseudogout. But again, if it's monarticular, you always want to aspirate to clinch the diagnosis with the crystal analysis and to rule out septic arthritis. So how do we treat it? It's the same with gout. You could use high-dose non-steroidal anti-inflammatories, but I would never use that in someone over the age of 65 or with important comorbidities. We could inject the joint, like the knee. That's an easy joint to inject, having ruled out a septic arthritis. Colchicine loading could be effective. And the most common way that we treat this is with oral or IV steroids as a taper, very much as for gout. Now, although this is a calcium crystal, there is no role for calcium-lowering agents. And the next slide shows you that the only metabolic condition that is a risk factor for pseudogout that is associated with hypercalcemia is primary hyperparathyroidism. Everything else on this slide has no association with hypercalcemia. So we don't lower serum calcium. Serum calcium alone is not a risk factor. There are other factors that we have yet to define. Now, this is an important slide because, again, for every person who is hyperparathyroid, we probably see 1,000 patients in the geriatric practice who are hypothyroid and who have diabetes. So these risk factors are the reason why I see so many patients with acute pseudogout in the geriatric practice and why it's important to keep in mind. I also mentioned that there is a polyarticular smoldering form of pseudogout chronically, which is known as the pseudorheumatoid pattern of pseudogout. And you make this diagnosis by taking x-rays of the hands. And instead of seeing the classic rheumatoid-like erosions, you may see joint space narrowing, but you'll see prominent chondrocalcinosis throughout the wrists, occasionally in the MCPs and PIPs. It's very important to distinguish smoldering polyarticular pseudogout from rheumatoid arthritis, because you're not going to want to give methotrexate or other DMARDs or biologics to someone who has pseudogout rather than rheumatoid arthritis. And then there's some rare associations between pseudogout and Wilson's disease and hemochromatosis. These are good on the medicine boards. They'll give you a young patient, a young woman with secondary amenorrhea, and you'll want to be able to think of hemochromatosis. These are not diseases that we are going to encounter in the geriatric practice. Of course, we do encounter a lot of osteoarthritis, and it's thought that perhaps by shear forces, we may be shearing off CPPD into synovial fluid. And so patients with osteoarthritis of a joint that come in with now that joint inflamed may very well have acute pseudogout superimposed in that joint. So we've talked about the clinical presentation, the associations, the way to make the diagnosis, how x-rays can be helpful, and the treatment. I now want to move on to the third crystal that causes synovitis in our elderly patients. And when the third crystal is called calcium hydroxyapatite, and when it's aggregated as a clump precipitate, you can sometimes see it as on the x-ray illustrated here, where it is causing acute calcific tendinitis or bursitis. This calcification is located on the supraspinatus tendon. Patients present with acute shoulder pain. Often, not only are they older, but they have diabetes, and that association has never really been explained. You see that there's no diffuse synovitis of the shoulder. They have localized tenderness in the subacromial bursa. You can sometimes actually feel a calcific deposit. And the treatment is to inject depomedrol near that area. And over several days, you will get complete relief of pain and then regain motion with physical therapy. When these crystals, rather than being clumped and precipitated on a tendon, are finally dispersed throughout the shoulder synovium, another disease is encountered caused by calcium hydroxyapatite, and that is known as Milwaukee shoulder. And the story here is that there was a rheumatologist, Dr. McCarty, who practiced in Milwaukee, and he took care of a large population of older women who had been working on farms in that area. And they had marked overuse of the dominant arm as farmers, with marked osteoarthritis as well as rotator cuff pathology. And what he observed was a rapidly progressive destructive arthritis with large effusions. Patients would present with acute pain of the shoulder, large effusions, I mentioned, limited range of motion. He got the sense, because it was episodic, that there must be a crystal involved, and he kept looking for crystals using his polarizing microscope and not seeing any. He then had the idea to give samples of these fluids to a colleague who had access to an electron microscope. And under electron microscopy, intracellular calcium hydroxyapatite was seen. So that's how we have proven that it is a crystal synovitis. However, unlike medical treatment of gout and pseudogout, this one is much less satisfying because it responds very poorly to the things that we use for those. And in fact, the main way to relieve patients of their pain and suffering is either through rotator cuff repair or total shoulder replacement. So the medical treatment of this crystal synovitis still leaves much to be desired. And here it is in the flesh. You see this poor lady with this huge effusion, which is of the shoulder, which is incredibly painful. If you look at her x-ray, she's got marked narrowing bone on bone in the glenohumeral joint. And furthermore, you see that the location of the humeral head is superiorly migrated, indicating that the forces that stabilize the humeral head and the glenoid, namely the rotator cuff, has been torn. So you've got the rotator cuff tear superimposed on severe glenohumeral OA, leading to Milwaukee shoulder. So that's it for the 3 crystals that cause synovitis, particularly in our older patients. It's one of the sets of diseases that I particularly enjoy diagnosing and treating, because unlike rheumatoid arthritis and scleroderma and a lot of other diseases that I treat, it's so much more satisfying knowing what I'm up against, knowing that the etiologic agent is a crystal, and then being able to develop more targeted therapies for that crystals and relieving patients. So thank you very much. I hope you found this helpful, and to always consider these possibilities in your geriatric practices when patients present to you with an acute synovitis. Thank you very much.